Okay, we're going to finish up now with what should be our third and final section of the respiratory system portion of our chapter, looking at how respiration is controlled on an involuntary basis, right? So we're dealing with autonomic nervous system, controlling this for us most of the time without us thinking about it, although it can be overridden, although you can sit there at your chair right now and hold your breath or breathe faster or breathe slower or whatever you want to do. You can do that for a while. But most of the time, most of us probably don't think about every single breath we're going to take. That's going to be controlled for us by the medulla oblongata, which we've seen before back in our chapter on the respiratory system, back down here at the base of the brain, top part of the brainstem. We have the medulla, which is involved with sending out signals to the intercostal muscles and to the diaphragm, telling them when they need to contract. So when these motor neurons are firing, we're going to have contraction of the diaphragm, contraction of the intercostals, causing us to, again, expand the size of the chest cavity, increase the volume of the chest cavity, decrease the pressure, and pull air in. Now, at some point in time, shortly after that, we're going to stop sending those signals to those muscles, and those muscles are therefore going to relax, and the elastic nature of the rib cage is going to allow it to spring back to its original configuration, and we're going to be right back to where we were before we started. Again, most of the time this is done for us automatically. You can override it for a while, but even there's a point to which, or at which, that you really can't override it indefinitely. Like, you really can't sit there and hold your breath so long that you pass out or somehow die because you held your breath. At some point, the brain's going to kick in, and even if you pass out, the medulla is going to start breathing, causing you to breathe at a somewhat normal rate again at some point in time. So we have now neural controls. We have conscious control over breathing done by the cerebral cortex. So if you decide, hey, I'm going to start breathing really fast, or I'm going to hold my breath, that's the cerebral cortex causing that to happen. The medulla is the other type of neural control, and this is the autonomic part of things. This is what's going to control the autonomic nervous system to make you breathe at a relatively regular rate when you're not thinking about it. We can also look at chemical controls. So the medulla has built into it chemoreceptors that are set to monitor levels of CO2 in the blood, kind of in an indirect, roundabout way by monitoring the acidity of the blood. So one of the really big misconceptions in this chapter that people have is that the body is somehow attuned to the amount of oxygen you have in the blood. And if you need more oxygen, you're going to breathe more. If you have enough oxygen, maybe you're going to slow down breathing a little bit. That is not the case. The actual trigger for rate of respiration is not oxygen, but it's instead CO2. Because when you have high levels of CO2 in the blood, that's going to cause the blood to become more acidic. That can be detected by chemoreceptors in the medulla, chemoreceptors in the carotid bodies and aortic bodies. Really important vital parts of the circulatory system are set up to detect any changes in pH that might occur as a result of either an increase or decrease in blood CO2 levels. And too much in either direction can be bad. So these different control points or monitoring centers are going to make sure they adjust rate of respiration accordingly when conditions start to change. So again, the neurons are very, very sensitive to changes in this P stands for partial pressure of CO2 in the blood. So if there's more CO2 in the blood, there's going to be a perceived need then by the body to start producing a faster rate of respiration. So more CO2 in the blood means more CO2 dissolved in blood plasma, which means you have more carbonic acid, which means your blood pH is going to get lower. And again, that can be detected by not only the medulla, but also the carotid and aortic bodies and their associated chemoreceptors. If that is the case, if those receptors are stimulated because of an increase or a decrease in pH, they can then send signals to the respiratory control center, which again would be the medulla, to increase rate of respiration. If blood pH drops, then blood CO2 is too high. This might be because you're not breathing fast enough. It could be because you're exercising and putting a greater demand for oxygen, or greater demand, more production also of CO2 on the body. So the medulla is going to increase rate of respiration accordingly once it gets those signals from these chemoreceptors. And so this would be the case where if you were to, say, hold your breath. You just take a big breath in, and you're going to hold it as long as you can. Now, at some point, different people differ. Some people can hold their breath for a really long time. Other people can't hold it for more than a few seconds. But at some point in time, your body's going to say, okay, that's enough. I've had enough of this. And it's going to go ahead and take a great big breath. Right? You're going to take that great big gasp of air after you've been holding your breath because your body has had enough. CO2 is built up to the point where it's crossed a threshold. And now the body's going to force you to go ahead and take a breath. There are also, and I mentioned the medulla, there's also sensors surrounding and in and around the spinal cord that can help detect changes in cerebral spinal fluid in the brain as well as the spinal cord to help monitor any changes in pH that might occur as a result of increases or decreases in blood CO2. So again, we have one of these lovely flowcharts here. We have one of two things. Either you're not breathing fast enough, or maybe you're exercising, your muscles are contracting more, so therefore they're using up more oxygen, which means, again, not only are they using oxygen, but they're producing CO2. In both cases, you're going to have an increase in blood CO2 concentration. So we can see the decrease in pH in the blood. We can see a decrease in pH of cerebral spinal fluid. In both cases, we have chemoreceptors either in the circulatory system or in the nervous system that can pick up these changes in pH. They're going to send, therefore, impulses to the respiratory control center of the medulla, which then sends out a signal to the diaphragm and intercostals telling them to breathe more, breathe deeper, breathe faster, whatever. And so these things down here are going to have the opposite effect of the things that cause the change in the first place. The breathing faster, breathing deeper is going to help overcome either not enough breathing or increased tissue metabolism, so you're breathing faster, you're breathing harder because you're exercising. And so it's, again, one of those negative feedback things. In this case, negative feedback is set up to help maintain a consistent level of blood CO2. Okay, so we're monitoring pH and adjusting accordingly. As far as other respiratory diseases, you may have heard of COPD before. COPD stands for chronic obstructive pulmonary disease. This is a large range of conditions. This is not just one thing. This could be anything that helps to obstruct airflow on a long-term basis. Something that's not acute. Acute means like right now, it's there, it's done, it's over, it's not coming back. Chronic means it happens over and over and over again. So it's long-term obstruction of airways. It could be asthma, like we've talked about before already. Previously, we talked about kind of the overall, what is asthma as it happens, but the triggering of asthma happens as a result of histamines, which are sort of an immune response to various types of chemicals you might come into contact with. So the allergens are the things that cause you to release histamines, which may then cause you to go into this constriction of bronchial passages. And in extreme cases, with extreme asthma attacks, they can actually be fatal. They can actually lead to suffocation. But the histamines that are released by your body in response to something that the body doesn't like. You may have heard of antihistamines before. So if you have an allergic response to something, whether it's pollen, whether it's mold, whether it's cat dander, whether it's whatever you're allergic to, antihistamines are going to help reduce the amount of histamines produced in the body and therefore reduce the allergic response to whatever allergen you might be suffering from. We also talked previously about emphysema, which is where you have a breakdown of the alveolar walls. So the lungs get less elastic, they're less stretchy. They also have fewer air sacs, they have less surface area. And so because of that, they're not able to get the amount of oxygen they need to perform even the most basic of daily tasks. From getting up and walking across the room, that could actually be exhausting because they're having to spend way more energy just breathing, much less walking up and down the stairs, walking across the room, running, jogging, something like that. It's impossible because they're literally getting exhausted just by trying to breathe, right? So much less anything beyond that becomes very, very difficult. In most cases, emphysema is relatively easy to prevent. All you have to do to not get emphysema is to not smoke, because approximately 80 to 90% of the deaths caused by emphysema are the result of cigarette smoking. Now, the other cases of emphysema typically occur in people who work in some sort of industrial setting. Maybe they're working around chemicals of some sort or materials to which they have no protective measures. And over 30, 40 years, those chemicals might start to cause breakdown of those alveolar walls and lead to emphysema, even though a person may not have ever smoked a cigarette in their entire life. But in most cases, cigarette smoking is the smoking gun when it comes to developing cases of emphysema, so to speak. So again, we take a look at alveoli. Normally, lots and lots of little tiny chambers, little tiny pockets and air sacs and things. But with emphysema, most of those finer walls break down, and what you end up with are larger cavities, much bigger air sacs, which have a lot less surface area on the inside. All these little walls now are gone. And so because there's less surface area, then it's much more difficult to get oxygen in, because like we saw before, surface area only helps diffusion. So if you take away surface area, if you have less surface area, like the cross-section through this, the wall of this lung versus this lung, this one has a lot less surface area, so it's going to have a much more difficult time doing gas exchange. Lung cancer is caused also typically by cigarette smoking. Oftentimes other cases involve cigarette smoking in combination with other kinds of chemicals. But this is one of the more lethal types of cancer. Lung cancer is one of the ones that has the highest mortality rate of any other kind. And again, this is caused primarily by smoking cigarettes. Often you'll find different types of COPD associated as well, whether it's chronic bronchitis, whether it's emphysema, those sorts of things. But the thing about lung cancer that makes it so deadly is it's very, very aggressive and very good at metastasizing. So what happens here is that the cancer cells break off from a tumor, travel throughout the blood, and become lodged in other tissues where they take up residence. So the lung cancer doesn't just stay lung cancer, it spreads to other parts of the body and becomes brain cancer or liver cancer or some other type of cancer, which can also be very problematic, right? So it's not so much that it's the effect on the lungs, although that certainly is very severe. These lungs over here I wouldn't necessarily call healthy. They look pretty gross, actually. Obviously, that person's going to have a fairly difficult time breathing, and that could eventually become fatal over a long enough period of time. But it's the cancer cells that spread to other parts of the body as well that helps to finish them off even sooner. Once that happens, the survival rate is extremely poor. Once the cancer metastasizes, it's only about 3% of patients that live even for 5 years after the cancer was first diagnosed. So it's fairly grim once the cancer is metastasized, and it's often difficult to tell whether or not a cancer has even gotten to that point yet. So treatment options become a bit of an unknown if you're not really sure yet if the cancer has begun to spread. If there's only 1 or 2 cells that have moved somewhere else in the body, they could eventually become established. But detecting those 1 or 2 cells could be difficult. So again, a single lung taken from a patient who is a heavy smoker, not a healthy looking piece of tissue. Now the common cold is like the opposite of lung cancer when it comes to severity. Like nobody dies from the common cold, but it's caused by a huge range of viruses. Typically it's 1 or 2 weeks you have a cold and then you get better. It's very, very easily spread from person to person. So it's again induced by a virus. Very communicable, very contagious, very easily spread from person to person, but not especially harmful. And that tends to be the case in conditions or diseases, especially things caused by pathogens. Things that are moving person to person and have that kind of mode of spread usually tend not to be quite so severe because they need to be able to keep their host alive long enough to get into that next host. Pathogens that are carried from the water, carried in the air, those kinds of things tend to be a bit more severe because they don't care if their host dies. In fact, if the host dies, all the better because then you've got more contagion out there in the environment, which can be spread to more and more hosts. The flu is one that is a respiratory disease. So right off the bat here, I'm going to give you guys kind of one of my pet peeves. When you hear somebody that says they had the stomach flu, right? So what they actually had was gastroenteritis, where they had some sort of stomach virus that caused them to throw up for 24, 36 hours straight. It's a horrible experience. I've had it. It's no fun. It is not the flu. The flu does not do that to you. The flu is a respiratory condition. Now, the flu can also be extremely severe and extremely deadly. It's a more extreme version of a kind of a similar set of symptoms as the cold, but it can also become complicated. You can have bronchitis set in, which is kind of my tendency. You can have pneumonia set in. You can have sinusitis set in. All those kinds of things can happen once you sort of move beyond the initial progression of the flu itself. Vaccines are pretty good. The vaccines that you get kind of on a yearly basis, epidemiologists do a pretty good job of predicting which flu strains are going to be the worst in a given year. They do, kind of the focus of producing the vaccines is on those specimens, the strains that are likely to be common. It's sort of a guessing game. Which ones are going to be bad this year? Let's make our vaccines against that one. Usually it's pretty good. But the issue is there's always new strains appearing because these viruses especially are notoriously bad at copying their DNA. That sounds like it should be a bad thing, right? They're bad at copying DNA. That can't be good, so they're going to die out. Well, what that means is, a lot of them do kind of die off, but because there are so many mutations and so many variants out there, inevitably some of them are probably going to be pretty good at surviving, and maybe they're even resistant to antibiotics and antiviral drugs and those kinds of things. Now, pneumonia is where you actually have inflammation of the lungs. And in this case, you're going to have fluid in the alveoli, which makes it much more difficult to do gas exchange. If you ever had or ever known anybody that had pneumonia, one of the first things they start to notice is that it becomes really, really difficult to breathe. And you're breathing and breathing, but you just don't feel like you're getting enough air, in part because the alveoli have at least partially begun to fill with fluid. The bronchioles swell up. Again, breathing becomes difficult. This one, again, can be fatal, especially in older patients or patients who are immunocompromised. Pneumonia is very frequently a source of mortality. But again, this one's usually caused by some type of infectious agent like a bacteria or a virus. Strep throat is caused by Streptococcus bacterium. Again, it typically tends to be one of those things that's more minor now because we have good antibiotics that work against it, at least for the time being. Historically, if you were to go back 100 or 150 years, it would not at all be uncommon to find patients who died because of strep throat. It's not typically for us. We don't think about strep throat and worrying about dying or worrying about our kids dying from it. You go to the doc, you get some antibiotics, you clear it up. It's not such a big deal, but that's because we have antibiotics, which was not always the case. Strep throat very frequently comes with the swollen glands we've talked about, with the lymphatic system. We've talked about fever before as well. Strep throat, if left untreated, can actually lead to rheumatic fever, which can become fatal and can cause other tissue damage as well. It can also lead to a type of kidney disease called glomerulonephritis, which is a swelling of something, a part of the kidney called the glomerulus, which is kind of the initial filtration step when it comes to getting blood filtered, a very important part of the kidney tubule. Tuberculosis, again, is caused by a bacterium called Mycobacterium tuberculosis. It's transmitted extremely easily, very, very contagious. For a long time, it was thought that tuberculosis wasn't really going to be an issue anymore. We thought we had maybe not eradicated it, but done a pretty good job of getting rid of it. But it is making a comeback, and even worse now, there are multiple drug-resistant strains of tuberculosis. So if somebody comes down with it, they go to the doctor, they get a shot of antibiotics, and it does nothing because the bacteria have evolved. We've selected out the ones that are most susceptible. We've selected 4 of the ones that are most resistant, and now our populations of Mycobacterium tuberculosis are fairly infectious. So they can start to show up again, and they have started to show up again, especially in crowded conditions like prisons, especially overseas where they're very, very crowded. Russia, for example. Tuberculosis is making a comeback, and it's thought that maybe 1 out of every 3 or so people during their lifetimes, and this is globally, this is not just in Russia or whatever, it's globally, 1 out of every 3 people will likely be exposed to tuberculosis at some point during their lives. This one, of course, too, can be fatal. Bronchitis, again, we've talked about this a little bit. This is more of a, not really completely chronic, but not necessarily acute either. It lasts for typically a week or 2 at least, where you have inflammation of the bronchial passages. The mucous membrane becomes inflamed. What that does, because of the inflammation, now the diameter of the bronchial passages is smaller, and so it's, again, difficult to breathe. It's difficult to have stamina and endurance and those kinds of things. This can be caused by a range of things. It can be pathogenic, where you've got a virus or a bacterium causing an infection. It could also be chemical irritation that's leading to the swelling of the bronchial passages, too. It could be either one of those. Lots and lots of coughing, lots of excess mucus. Not a very pleasant thing to suffer through if you've ever had bronchitis. All right, so that's the end of our chapter on the respiratory system. We are going to wrap this up, and we will move on to the next section.